The last two speakers are going to talk on Cryptococcus. I do believe this type of infection is one of the great studies of clinical medicine and infectious disease and antifungals. The first speaker is Tom Harrison from St. George's. He is going to talk on Pan-African cryptococcal studies. And what you see here, and I suspect without knowing exactly what he's going to say, is how they've taken steps in antifungal treatments, learning from one step, going to the next step, going to the next step. This is a paradigm for studies of fungal infections, in my opinion. And Tom has done this for many, many years, and it's our privilege to have him here to talk on it. So, Tom.
Thank you very much for the invitation to talk. Thank you very much for the introduction, John. So I'm happy to talk about Pan-African cryptococcal studies. Do I have to point this somewhere? Or? Yeah. Okay, so I think all of you in the audience will be aware of the very high ongoing mortality burden of cryptococcal meningitis in Africa, and the fact that this is being driven in significant part by the inadequacy of previously available antifungal regimens in Africa. So what I'm going to tell you about today briefly is the two phase 3 studies, the ACTA trial and the Ambition trial. Give you a very brief overview of the background rationale for these trials and summarize the results, but then give you an update of ongoing implementation efforts and also the likely impact of these trials, and end with a couple of reflections. So I'm going to talk to you about treatment trials for cryptococcal meningitis in Africa, and so that doesn't give me time to talk about another very important element of work going on in this field, which is optimizing our CRAG screening and preemptive treatment strategy to actually try and prevent cases of clinical cryptococcal meningitis developing in the first place. The ongoing Acacia study in Uganda and the EFFECT trial in South Africa and Tanzania. So what about the ACTA and Ambition trials? So they actually share a basic background rationale. These two studies were built on a series of phase 2 studies carried out over a number of years, and the essential challenge was to develop some novel regimens that, number one, would be much more easily and feasibly sustainable in Africa, could be given safely in Africa, and would be less toxic than the standard international treatment of 2 weeks amphotericin B deoxycholate and flucidazine, which essentially hasn't been available in Africa, or hospitals in Africa haven't been able to use this regimen safely. On the other hand, the new treatments had to be a whole lot more effective than what has been the mainstay of treatment over the years in most of Africa, which has been fluconazole monotherapy, with which we know that the mortality with that treatment at 1 year will be around 3/4, in fact, maybe over 3/4. So I'm just going to summarize for you here quickly the results of a number of these phase 2 studies that led to the phase 3 trials. And essentially these were studies based on a new endpoint, the early fungicidal activity, and they led to 3 hypotheses that needed taking forward and testing in phase 3. Number one, we needed much bigger doses of fluconazole. So we moved from 400 milligrams a day up to 1,200 milligrams a day. It was more effective and certainly appeared to be safe. Number two, addition of flucidazine to high-dose fluconazole further improved the antifungal activity, and in addition, suppressed the development of fluconazole resistance in elegant work by my colleague Tihana Bicinic at St. George's and Neil Stone. And thirdly, that shorter courses of amphotericin B deoxycholate, just a week, could give you all the efficacy in terms of antifungal effect, but you'd miss out significantly on the toxicity of the drug by giving a shortened 1-week induction course. In the ACTA trial, we asked one further very important practical question, which is what is the best partner drug to give with amphotericin B? Is it the traditional flucidazine, or is it a fluconazole more easily available in Africa? So these were the treatments given in the ACTA trial. The two experimental strategies, one was this optimized oral combination of high-dose fluconazole and flucytosine. The second was the amphotericin B given for 1 week, and they were compared against the international standard of amphotericin B deoxycholate for 2 weeks. And then within the amphotericin strategies, patients were randomized additionally 1-to-1 to receive either fluconazole or flucytosine as the partner drug. And then after the first 2 weeks, then everyone gets the same standard consolidation and maintenance with fluconazole. So this shows you the bottom line result of the ACTA trial was that all three strategies performed equally well, as shown on the survival curves. In fact, the blue is the oral, the red is the 1 week ampho, and the green is 2 weeks amphotericin B. So no significant difference at all in mortality. What we did, however, see was a clear result in terms of the partner drug in favor of flucytosine in the red here on the survival curve. So very significantly improved survival with flucytosine given as the partner drug, as shown here. And this mirrored, in fact, increased antifungal effect, fungicidal activity with flucytosine as the partner drug with amphotericin B. So in fact, in ACTA, if you broke down the 5 different treatments given in the trial, by some way, the best treatment was 1 week amphotericin B and deoxycholate and flucytosine, with a pretty remarkably low, compared to prior trials, 10-week mortality of 24%. And in fact, that was significantly better than 2 weeks amphotericin B and flucytosine, as shown there. And it was gratifying to see that the benefit of the 1 week ampho and flucytosine arm was sustained right out to 12 months, as shown on this graph, results from a follow-up of a substantial subset of the patients in the trial, 230-odd patients in Malawian sites, with complete follow-up data to 12 months. So you see very little ongoing mortality in that arm. So we thought the results of ACTA were explicable by it was a balance between the antifungal effect, the fungicidal activity of the regimen, and their tolerability. The rate of clearance we saw with the 1 week ampho arms was as rapid as with 2 weeks, as we'd seen in the phase 2 studies, but clearly we had much less anemia, much less renal impairment. The oral regimen was very well tolerated, and it was non-inferior to 2 weeks amphotericin B, even though the rate of clearance of infection was less rapid. So these results were shared with the WHO so that after publication of the trial, they were ready to come out with updated guidelines, and they recommending the 1 week amphotericin B deoxycholate and flucytosine as the preferred regimen, and the oral combination as the alternative, especially, of course, where amphotericin B was not available. But obviously, these recommendations depended on having improved wider access to affordable generic flucytosine. Fortunately, with advocacy from across our field and driven by the results of the trial, we were able to persuade Unitaid to initiate this considerable program, $20 million, to support advanced HIV care. And an important part of that package was provision of generic flucytosine to 8 key countries. In addition to that, there was this flucytosine access program in South Africa, with the Department of Health in South Africa and the MSF in South Africa, led by Nilesh Govenda, who has actually been doing surveillance of the in-hospital mortality of cryptococcal meningitis in South Africa for many years, supported by the CDC, Tom Chiller and his colleagues from the CDC. So they introduced flucytosine in Africa, the 1 week amphotericin B deoxycholate plus flucytosine regimen, in a structured fashion across the sites across the country, as you see there. And this just shows you the bottom line results of that access program. And in fact, the 1 week ampho and flucytosine 5FC regimens there in the chart, in-hospital mortality for the first time in South Africa significantly reduced from 37% down to 24%. And obviously that's mirroring the benefit we saw in the clinical trial. The other regimens there reflects the standard practice in South Africa prior to ACTA, which was 2 weeks amphotericin B and fluconazole as a standard treatment given in South Africa. And this has just been actually published just very recently now with Rudzani Mashau as the first author in Lancet Infectious Disease. So I want to move on now and talk about liposomal amphotericin B, Ambisome. And of course, this drug's been around a while. We know very well from prior trials that it's not more effective per se than deoxycholate, but it's certainly a whole lot less toxic, so less anemia, less renal impairment. It's also got a huge long half-life and excellent brain tissue levels. So we thought even better suited perhaps than the conventional drug to the concept of short-course, high-dose induction treatment aimed at loading brain compartments. And of course, there was precedent for this use of single high-dose Ambisome in visceral leishmaniasis, the work of Syam Sundar in India, showing that just one 10 milligram per kilogram dose was effective treatment for visceral leishmaniasis in India. And obviously, if one dose was part of an effective regimen, it could be a cost-effective regimen and also a very practical one, even though the drug per se is more expensive. So this was, again, a phase 2 study based on early fungicidal activity, just the single 10 milligram per kilogram dose on day 1, or give an additional backup dose on day 3, or give 2 backup doses on day 3 and day 7, compared to standard daily dosing of the drug over 14 days. And all the patients, in addition, got high-dose fluconazole. So this shows you the results of the phase 2 study, and essentially all the intermittent Ambisome regimens performed as well, were non-inferior to controlled daily dosing of Ambisome. And also we noticed immediately when we started using this drug how much better tolerated it was, how much less anemia and renal impairment we were seeing than we had seen in ACTA and indeed in other trials of deoxycholate in Africa. So we took forward the single high dose of Ambisome. We backed it with a optimized oral backbone, as used in ACTA, of high-dose fluconazole and flucytosine for 14 days, and we compared it against the new WHO standard based on ACTA of 1 week deoxycholate plus flucytosine. Again, an all-cause mortality 10-week endpoint. That's top right is Joe Jarvis, my co-PI on the study who led the trial, and on the left-hand side there in the middle, David Lawrence, who was the lead clinician for the trial with Nabila and Philippa, and of course a fantastic array of colleagues and collaborators from across the sites in sub-Saharan Africa and their teams. So this is the headline result from the Ambition trial that was published relatively recently in New England Journal. So the mortality with the Ambisome single-dose regimen, 24.8%, and with the control 1 week regimen, 28.7%. So very, very comfortably meeting the predefined non-inferiority criteria, even if the criteria are set at a more stringent level. And I should say, also reiterating the good results with the 1 week regimen, with sub 30% 10-week mortality, as we'd seen in the ACTA trial, which is obviously a step change compared to the prior results. This shows you the non-inferiority plots in the Ambition trial, and you'll see in adjusted analysis that actually the single-dose regimen is on the borderline of superiority. This is the Kaplan-Meier survival curves. And this is the EFA, the clearance curves. And with the single-dose regimen, we were able to match the EFA of 7 daily doses of 1 milligram per kilogram of amphotericin B deoxycholate here. There's no meaningful difference in the EFA of the 2 regimens. What there was a difference in, again, was in the tolerability, and I've just picked out the drop in hemoglobin there. The Ambisome regimen was really extremely clean. There's a minimal drop in HB there, contrasted to still a significant drop in hemoglobin, even with 1 week of deoxycholate. And of course, also less renal impairment with the Ambisome regimen and less thrombophlebitis. Embedded in the trial as an intrinsic part of the trial was a formal health economic analysis, and the finding there really was that although the Ambisome is a more expensive drug, as a proportion of overall costs, it's only modestly more expensive in terms of the overall cost of the treatment than the control regimen. And because of that, the cost per life year gained is really very modest at less than $100. In fact, the regimen could be cost-saving if, on average, it allowed patients to go home just maybe 1 or 2 days earlier. That could make it cost-saving, as could, of course, if the cost of flucytosine was further reduced. It's already been about halved since the time of the ACTA trial, the cost of flucytosine, or indeed if the cost of liposomal amphotericin B could be reduced. So, in conclusion for AMBITION, yes, single high-dose ambisome given with flucytosine and fluconazole was non-inferior to the one-week regimen. Same clearance, fewer adverse effects, and even more practical, easier to administer, better tolerated treatment for HIV, cryptomeningitis in Africa. But as now, of course, we need the ambisome as well as the flucytosine. Well, I should say these results were also shared with Nathan Ford and his team at WHO, and they again, after publication of AMBITION, have updated the WHO guideline to recommend the single-dose regimen. And the country guidelines, so the countries where the trial was done, are also in process of updating their guidelines. That's already happened in Malawi and Botswana. I think it's pending very shortly, hopefully in Uganda. David Mayer can comment, and also we know in Zimbabwe. And in fact, patients have already been treated in routine care with this regimen in Malawi and Botswana and Eswatini. And this has been enabled by the fact that, fortunately, that UNITAID program, I think with considerable foresight, as well as providing flucytosine, had already got in place ambisome in these 8 key countries where they were working. And so we've really got a head start with in terms of implementing the AMBITION regimen. Plus, some countries have already started requesting and receiving flucytosine through the Global Fund. So they won't be. So there will be a mechanism whereby these drugs will remain available after the UNITAID program finishes. In addition, we've got some further implementation funding. And again, the CDC, with Tom Chiller and colleagues, are providing some support to Joe and David to continue the implementation work in the trial countries where we're working. And in addition, we've got a UK, what's called an NIHR Global Health Group a grant on HIV-associated fungal infection, which incidentally I think is a good step forward for our field, which includes implementation of the AMBITION regimen, working with MSF in different countries, in DRC, Guinea, and Mozambique. And of course, Gilead have committed to supply the drug at preferential pricing levels for the indication of cryptococcal meningitis. So what about the impact? I think the fact is that this can lead to a sustainable reduction in mortality. And however you calculate the burden, this can lead to thousands of lives saved every year. I should say that I think the single ambisome regimen in routine care, the benefit over the deoxycholate regimens could be even more than we saw in the trials, because remember, in routine care, it's pretty challenging to monitor and manage the deoxycholate side effects, as well as is necessarily put in place in the context of a trial. Having said that, I think the other good thing is that we now have a range of regimens. So if you don't have ambisome, the single dose, the 1 week amphotericin B deoxycholate and flucytosine can give you the same mortality benefit, if delivered properly, as the single dose regimen. And if you don't have any ampho at all in any formulation, then the high-dose fluconazole flucytosine oral combination, remember that almost halves the mortality compared to the previous use of fluconazole monotherapy. So the bottom line is more of our patients at one moment facing death are going to actually leave hospital. So I just, coming to the end here, I just reflect on a couple of things. I think the phase 2 studies here were critical in this program of work based on the early fungicidal activity endpoint. It allowed us to efficiently test and select regimens for testing in phase 3 and gave us increased chance of success in phase 3. And I just also reflect the fact that academically led trials, post-licensing trials, can sometimes play an important part in improving treatment outcomes through optimizing the dosing, the scheduling, the combinations of drugs. But ideally, more of this work could be done earlier in the drug development process. And I was just interested to hear Jack Sobel mentioning the fact that after licensing, we still need to learn how best to use the drugs for vulvovaginal candidiasis. So I want to just obviously emphasize that the ACTA and Ambition trials were huge efforts by very many people across sites in sub-Saharan Africa. This is a list of investigators for ACTA. This is a list of investigators for Ambition. And these are our funders for the trials. And I just want to leave you with this one quote from one of the trial participants in Ambition from Kampala. And please, I do recommend you looking at this paper in Social Science and Medicine, maybe not a journal we all frequently look at too often. This is by David Lawrence, the lead clinician in Ambition. He's doing a PhD on social science, and it's really very well, I think it's important to hear from the patient's side, their experience of the disease, and of course their experience of being part of a trial. So I don't have time to read that out, but am I within time, John? We can perhaps just leave it up for a few seconds. I'm finished there. Thanks very much.
Please leave that up for a minute. Thanks, Tom. And it shows how, with a sequence of events, that you can really study this thing and improve the outcome of a serious disease process, and very eloquently done.